We know that sepsis, if you take sepsis, sepsis is a primary cause of death in the ICU. It's a primary cause of death outside the ICU. And even if we are the best intensivists, we provide the best care in terms of antibiotics, in terms of source control, in terms of organ support, then you will still end up with a lot of patients dying. And so we need an adjuvant treatment. And hemoadsorption during the last few years, a few decades, I think now we have strong evidence that it could become a very good, strong adjuvant to decrease the mortality rate of septic patients. You can observe these three effects. Of course, the most important effect you observe first is the hemodynamic stabilization. When you provide hemoadsorption to your septic shock patient, you can see quite, in some patients, not all of them, but you can observe a huge decrease of the norepinephrine requirement. And I think this is the main first observation you can make. And that is very important because if you decrease the norepinephrine, if you improve hemodynamics, then you can improve also other organ functions, and you hope you can improve survival. Well, that's a very difficult question, how to decide how many sessions you're going to do. 1, 2, 3. I think the best approach is to look at the response of your first session. If there is a good response, if you have hemodynamic stabilization, if you have a patient that you feel is getting better thanks to your first session, then I'm going to do another session because I am on a good path. I think the patient responds correctly to the therapy. Then I'm going to do another session, maybe 2 or 3 sessions. If, on the other hand, if the patient does not respond to the first therapy, I don't think this is necessary to try again with another session. Of course, effectiveness, this is very difficult, but we just said that sepsis is the primary cause of death in the ICU, primary cause of death outside the ICU. That means it's very expensive. Sepsis is very expensive in terms of healthcare costs, right? You have patients staying in the ICU for days, weeks, months because of sepsis. And if you can improve a little bit organ dysfunction, and then if you can decrease, for example, the ICU length of stay or the hospital length of stay, you will be able to save a lot of money, actually. It's very difficult to evaluate cost effectiveness because you have to put everything together to calculate the cost effectiveness. So even if the cartridge is a little bit cost like few hundreds of euros, I don't know exactly the price, but even if it costs a little bit of money, then you can save money after because of the effect. I think this is very important. Yes, I have a message to share with my colleagues. Because of the negative trials that you can find in the literature, like large multi-center randomized controlled trials, some of them are negative. And you can hear in many meetings, in many places, that hemoadsorption, all these devices, all these blood purification devices just do not work. Actually, I would like my colleagues to understand that all these trials, most of the time, the patient selection was not very good. And so you need to have a lot of septic patients included in these studies. And that's why these studies were negative. These studies lack patient selection. If you select correctly your population, then you may end up with positive trials. I think this is a very important message. And so we have to design correctly our studies to select correctly the population to find good results.